Welcome back. We're continuing with the anxiety disorders. And this time we want to look at post-traumatic stress disorder. Post-traumatic stress disorder is the development of a disabling psychological symptoms of an individual after experiencing a traumatic event that is considered to be outside the realm of usual human experience. Such traumas include rape, assault, military combat, natural disasters, serious accidents, and violent crimes against one or one's immediate family. This condition was first identified during the First World War when soldiers were observed to suffer chronic anxiety, nightmares, and flashbacks for months or even years after the battle. What are the signs and symptoms of post-traumatic stress disorder? They include sleeplessness, nightmares, phobia-like avoidance of the situation, recollections and intrusive thoughts about the situation, unpleasant dreams, depressed mood, impaired cognition, generalized anxiety. How do we manage any individual suffering from post-traumatic stress disorder? Management is as of generalized anxiety disorder. We give systematic desensitization, relaxation therapy, friends to support him, family therapy, cognitive therapy, and sometimes we give antidepressants. The next anxiety disorder I want to look at is obsessive compulsive disorder. Obsessive compulsive disorder or obsessive compulsive state. An obsessional compulsive disorder is a terrible burden to the patient and his family. It can torture patients almost for a lifetime. Let's look at these few definitions. Obsessional compulsive states. The patient is continually morbidly preoccupied with certain ideas or is compelled to perform certain actions that may occupy the whole day. That is an obsessional state. Obsession is a fixed or repetitive thoughts or ideas. So note this one carefully. Obsessions are fixed or repetitive thoughts or ideas. So in obsession, there are thoughts or ideas in the patient's mind. The patient himself recognizes them to be abnormal or irrational and tries to resist them. The event being recognized by the sufferer as foreign to his personality and into the nature of which he has insight. Then let's look at compulsions. Patients feel compelled to carry out a certain pattern of behavior. That is, he must think or act in a certain way and or is unable to exclude these compulsions from consciousness. So compulsions, as against obsessions, is the carrying out of the thoughts or ideas. That is what we mean by compulsions. So patients feel compelled to carry out a certain pattern of behavior. That is, he must think or act in a certain way and or is unable to exclude these compulsions from consciousness. Then we have resistance. Resistance is a deliberate attempt by the individual to prevent unpleasant thoughts from occurring. The patient experiences serious anxiety in the process and would then allow the thought to occur. What is the occurrence of OCD, that is obsessive compulsive disorder? It can occur in other illnesses such as schizophrenia, depression, organic brain syndrome, etc. It occurs between the ages of 10 to 25 years and is common in childhood and early adulthood. It occurs more often in women than in men, a ratio of 3:2. What are the causes of obsessive compulsive disorder? The affected person is often a child of an obsessional parent who was brought up in an atmosphere of excessive rigidity or broken or unhappy home. The pre-morbid personality for obsessive compulsive disorder is called the anancastic or obsessional personality. And this personality, it is characterized by overly cautious, quiet, and reserved, lonely individual, easily worried by the criticism of others, and they have excessive orderliness, and they are very rigid in thinking, and sometimes they are shy. Obsessive compulsive disorder, it runs in families. It is hereditary, or there's genetic predisposition. And to OCD is shown by relatively high incidence of the condition among siblings. This is not conclusive, however. Let's continue with the causes. There is some evidence of deficiency of the neurotransmitter serotonin in the brain. Psychological causes. The psychoanalytic viewpoint is that the condition results from fixation at the end of the phase of psychosocial development. All the above are predisposing causes, that is pre-morbid personality, hereditary, biological, and psychological causes. What are the precipitating factors or the precipitating causes? Psychological stresses from the events like bereavement, unemployment, or job-related stresses. Organic factors may include conditions that may occur as a symptom of other disease conditions like depression, anorexia nervosa, schizophrenia, dementia, etc. What are the signs and symptoms of an individual suffering from obsessive compulsive disorder, OCD? The symptoms include obsessional thoughts. Obsessional thoughts. These are ideas or words and beliefs which come into the mind without his wish. The individual, in an attempt to get rid of these thoughts, suffers severe anxiety. Another symptom is obsessional doubts, also called folie du doubt. Here, the affected person is compelled to believe some action he has performed was not completely adequately done. Example, he may not be sure he properly closed or locked the door before leaving home, or that his tie is not properly fixed, or gas not properly turned off, or iron not switched off, etc. Intense doubt may lead to the action being rechecked or redone over and over again. Then we have what we call obsessional rituals. This involves mental activities like counting things repeatedly or repeating certain words. The rituals can be behavioral, like washing hands 30 or more times a day, or washing hands in a particular manner, or bathing for more than 1 hour in the bathroom. Then we have obsessional impulses. These are strong urge to do some silly thing. Example, shouting obscene words in public or injure somebody. Then we have obsessional rumination. This is endless debate in one's mind for or against a common activity like going to church. The person may ask that, why do we go to church? Then we have signs and symptoms. Let's continue with that. We have obsessional slowness. This results from the person's preoccupation with his thoughts or rituals, so that daily activities are done extremely slow. Then, of course, in obsessive compulsive disorder, one of the symptoms that the individual presents with is anxiety. This is the root cause of the obsession. The thoughts and rituals are actually means of trying to prevent feeling anxious. Then, of course, OCD patients also suffer from depression, usually results from obsessional symptoms or may be spontaneous. What are the effects of the symptoms of OCD on the individual? So let's first look at the physical effects. There's delayed or inadequate sleep as a result of ritual or thoughts. There is excoriation of skin as a result of repeated hand washing or chemicals. Infection of the skin from excoriation. Malnutrition if food intake is less than body requirement. Bodily illnesses such as hypertension from anxiety and other stresses. Effects of obsessional symptoms. Let's continue and look at the social effects. There is conflict or quarrels as a result of rituals or slowness. Example, delay in the bathroom. Here, maybe you are in the students' hostel where everybody is hurrying up to come for lectures that start at 7:30. At a particular time, everybody wants to bath, and the OCD patient goes to the bathroom and spends over 30 minutes to 1 hour. It causes conflicts. There is loss of job due to lowered productivity at the workplace, social isolation or withdrawal while performing rituals or ruminating. Anger or aggression may ensue from attempts by others to prevent the rituals. There are also economic effects. In the economic effects, there's decreased household income, poverty as a result of unemployment, high spending or clothing due to frequent replacement, There's also low productivity, or low productivity would lead to low income if self-employed. How do we manage an individual suffering from obsessive compulsive disorder? We give physical management, and the physical management we give drugs such as anxiolytics, antidepressants, and sometimes we give electroconvulsive therapy if the patient is depressed. Psychologically, we give psychotherapy, and the psychotherapy we give here is supportive psychotherapy. We also provide ordered regimen to reduce the rituals, and sometimes we give occupational therapy, or occupational therapy may be of value in diverting the parent's attention. Then we also give what we call the behavior modification therapies. An example is desensitization. I've explained what it is. We also use flooding. I've also explained that already. And then we also use thought stopping. In thought stopping, when the patient is thinking about the ideas and you are in the presence of the patient, you just shout onto the patient, say, "Stop!" And then the patient will stop thinking about what he was thinking. How do we care for these patients, or the nursing care of a patient suffering from obsessive compulsive disorder? Establish and maintain good nurse-patient relationship. Provide for patients' basic needs, which includes nutrition, warmth, grooming, rest, etc. Allow patients sufficient time to perform rituals if they allay anxiety in the acute phase. Of course, we don't have to do that, but in the acute phase, if it takes away anxiety, we allow them. Use a warm, caring approach at nursing to prevent the patient feeling being forced to abandon anxiety-relieving rituals. Be firm and consistent with one approach to patient. Occupy patients' free time with structured and simple tasks to reduce ruminations and rituals, and assist patient in setting limits to his behavior. These are the reading lists that I want you to look at and read and get more on obsessive compulsive disorder and other anxiety disorders.